you. As mentioned, we are halfway through. Warm welcome to one and all, and warm welcome to Rutula Sonawane also. And as we have been told that halfway through is all of you are aware of many things about palliative care. And there are some myths. Oh, does it cover something alone, not the rest? That also, those queries will be wiped away today by Dr. Rutula Sonawane, who is an assistant professor in palliative medicine at the Department of Critical Care Medicine in Bharati Hospital, Pune. She has obtained a master's degree from Tata Memorial Hospital, Mumbai, and working currently at Bharati Hospital. And her main interest is palliative care in non-oncology and pediatric populations. So who else should be the best person to take us through this session? And her main interest is to make palliative care available to whoever needs it and improve the quality of life too. With that, I hand over it to you, Dr. Rutula, to take us through the session today.
Thank you, ma'am. Hello, everyone. Welcome to the session on palliative care in non-oncology. I'll just be sharing my slide. So let's just give me a minute. Can you all see it?
Yes, we can see, Rutula. You want to make it as a slideshow?
Yeah.
That's it. It's all set to go.
Yeah. Welcome everyone. So we'll be talking about palliative medicine in non-oncology setting. So just to briefly revise over what palliative medicine is and what we've already seen before. So as you all know that it is an approach that improves or rather aims to improve the quality of life in patients, both adults and children, and their families also, who are facing problems associated with life-limiting illness. Now, this we have to do with impeccable, that was the initial definition. So by early identification, proper assessment of symptoms, which may be either physical, psychological, social, or spiritual. So I'm sure you've seen this graph before. I'm just emphasizing on it because it's important to note. So initially, palliative medicine was thought to be only hospice care or only end-of-life care. So it was only in the last part of the disease trajectory that our involvement was there. But over the period, as the branch has developed, now it is seen that it should be started as soon as a life-limiting or an advanced chronic disease has been diagnosed. And it goes hand in hand with the disease-modifying treatment and also extends beyond the death of the patient to bereavement care. Now, though the graph is linear, it is important to know that it is not linear. Our consultation may be more sometimes and less the other times. So it is not a linear graph. It is up and down. Wherever we are needed more, our input should be more. So it's important to remember it's very flexible and very fluidic. But it starts from the diagnosis and extends beyond the death of the patient. So again, to emphasize that it should be an integrative model where symptom management and other psychological or social management goes hand in hand with disease modifying agent and may proceed either to survivorship and rehabilitation or end of life care and bereavement. So there are certain competencies that we as palliative care physicians should have. I'm sure you all have know this, but I'm just kind of going briefly through this again. So basically, we should know what a palliative care of approach is. We should know how to approach or how to understand that the patient needs palliative care or supportive care, if you don't want to use the word palliative care. Then we should be able to address and management pain, which is one of the most commonest symptoms, not only in oncology, but in non-oncology as well. And other symptoms like fatigue, depression, anxiety, cachexia, anorexia, etc. And this should be done by a thorough and proper physical examination, history taking, and relevant investigations as needed. Then we should be able to participate in a proper care of the dying patient and their families. So this includes identifying when the patient is dying, identifying what are the natural signs of dying process, and how would you prepare and educate the patient family or the caregivers when death approaches, and also extend it to the proper care of the dead body. Then to address psychosocial and spiritual needs. Now there are multiple tools for psychological assessment, social assessment, and spiritual needs. So using those tools or screening methods regularly, so that we can identify those needs as soon as possible and address them accordingly. Manage the symptoms well. If you need an input from specialists from those areas, then getting those involved in the care of the patient is also a good idea. So for example, a psychologist or a psychiatrist in psychological needs, a social worker for social problems or social needs that they might have, and spiritual leaders or pastor or anyone can be involved to address those needs. Then we should be able to address the end of life care decision, the decision making process, the planning process, which is generally based on the local guidelines and the local legal framework. So the recent Supreme Court verdict on end of life care decision and advanced care planning has made it a bit more simplified. Though, and I'm sure it will be adapted state-wise so that they have a few modifications, but it should be fairly simple now to make these decisions and to proceed further. So just get the input or get the guidelines for the area that you're working in, and maybe formulate a simple guideline for your institute so that it is easier to apply to the patients who may need it. Then communications is another very important skill set to have, especially as palliative care physician, because we need to communicate effectively with the patient and the family members. We need to be able to give them the bad news or whatever news it may be, very empathetically and very supportively. They should feel that they should not have a feeling of abandonment, and understand the situation as well as they can, and cope up with the emotions as well as they can. Then it is very important to note that all the symptoms that we might study are always multifactorial. They have a physical component, they have a psychological component, they may or may not have a spiritual component, and they have a social component as well. So when you want to address and manage a symptom well, you need to find out if there are any additional components to the suffering or to the symptom, and manage it holistically so that the care plan that you give is the best for the patient and it's managed well as well. The last one is to have self-awareness regarding your burnout and self-care. You should understand that since we are dealing with such high stress and sort of a very negative emotions all the time, or sad emotions all the time, we have a lot of stress and anxiety amongst ourselves as well. And to notice them soon or early so that they can be managed, and thus it does not hamper your caregiving to the patient. So always be aware of yourself as to when you may or may not develop self-stress or self-burnout. Now, I'm sure you've seen these graphs. These are called the 4 roads to death. So the first one is basically a sudden death, where some certain event occurs and the death occurs very suddenly. Graph B is for terminal illness, more specific for oncology, where the disease is stable or the health is stable for a certain period of time when the disease modifying treatment is going on. But as the disease starts progressing or it stops responding to your treatment, it gradually, the functionality gradually decreases and leads to death. Graph C is specifically for organ failures, where there is exacerbations of the disease intermittently, which leads to decline in the function, coming back to near normal level of functionality, but never actually reaching the baseline. So as you can see, the graph goes down, never reaching the baseline as it was. And the health deteriorates or the functionality deteriorates after each exacerbation and eventually leading to death. Graph D is old age or frailty or natural aging process, where the functionality has decreased over time because of the aging process. So as you can see from these graphs, graph B, C, and D would require some sort of palliative care and supportive care during the course of their trajectory. So, and from here, you can also realize that the majority of it is in non-oncology rather than oncology. So a greater need for palliative care in non-oncology as well. So what are the likely diseases that are that will benefit from palliative care or palliative medicine? Is your organ failures, your neurodegenerative diseases, your rheumatological diseases, you have your cancer, of course, you have your prolonged ICU illnesses, where let's say the patient has been in the ICU for more than 20 days with multi-organ failures, which is not responding to the treatment anymore. Then I've not mentioned it here, but you'll have your geriatric population as well, though it's more or less a separate branch nowadays, but geriatric care also comes as a part of palliative care. Now, quickly, can anyone tell me what are the potential barriers you feel for not involving palliative care in non-oncology? I'm sticking to non-oncology now. So any particular barriers that you feel are there? So we'll divide it in from a physician's perspective and from a family or patient perspective. So can anyone quickly tell me what are the likely barriers from a physician's perspective? Do you? You can type in the message as well. Lack of time, yes. Lack of awareness, yes. Anything else? Ego issues, yes. Awareness amongst the primary care team. Okay. Accessibility is difficult. Yes, that is another thing. Very few centers across don't feel the need, as patients will be fine later on. Okay. Anything else? Okay, so let's go in. So basically, the physicians always want to cure. They are like, I'm giving the medicines, they will get better. There is no need for any other input from anyone else. Then they feel like they'll be giving up on the patient, and so that kind of percolates into being their personal failure. So again, the ego issues, as you correctly said, and lack of knowledge, or rather lack of awareness about that palliative care can be used for non-oncology as well. And we have a few more which is that they don't feel the need, as the patient would be better, and accessibility of palliative care as well. So can anyone tell me from a caregiver's perspective? So you have your lack of willingness from the patient side. Yes, failure to accept that it is a terminal process. Yes. Specific from a patient or a caregiver side, any barriers you feel are there? Financial issues. So sometimes, financial issues might be the reason why they opt for palliative care. Even when there is like maybe like 5% some chance of recovery, but financial issues might push them for palliative care sometimes. It can go both ways, basically. So basically the disease trajectory, as we saw, it has a lot of up and down, and since it's gradual over a lot of long period of years and years or decades, sometimes they feel that patient is fine, the disease is not going to lead to death. They don't understand, they fail to understand that internally the organ is getting damaged, and the dependency is increasing over the period of time. They fail to understand that. So the disease trajectory makes it very awkward. Like, for example, if when you compare it to oncology, the diagnosis of cancer itself spells doom for them. Yeah, like cancer ho gaya hai, the patient is going to die. So, and for the rest of it, the awareness that it is a terminal disease, or it, kind of worsens over the period, is not so much. So the disease trajectory makes it difficult for them. And of course, they want everything to be done for the patient, and because, they're loved ones, so they want everything to be done. So they don't accept the fact that we might not go for further care, or rather escalating it to further care, or withdrawing from a certain life supporting treatment. So they are not ready to accept that. They have certain guilt amongst them as well, that they are not doing what can be done. They are thinking more in terms of not giving the treatment rather than what can be done. So that guilt is there, or rather the guilt that they might be the ones who are sort of killing the patient. And of course, we have societal pressure, especially in our country, where we do have to think about what the other people will say, because there are extended families who later on will say that, oh, you didn't do this, you should have done that, you should have taken him to that hospital, and etc. There are a lot of societal pressure as well, so that needs to be taken into account as well. So these were the certain barriers. So basically, now we'll be going system wise. I am not going into the details of each of the diseases. We'll be going down system wise. We'll take down the most common symptoms in those systems and discuss the management of the same. I would like you all to pitch in if you feel that whatever you feel is the right one, and you can ask any queries as well. So coming to the central nervous system, basically the commonly seen symptoms would be your seizures, your plasias or paresis. You'll have your dystonias, either hyper or hypo. You'll have your dysphagia and your aphasias. So coming to the management, we have our rehabilitative measures. So rehabilitative measures will be in all the system or all the diseases, because some sort of rehabilitative measures can be given for each and every one. So rehabilitative measures would be a common thread in all. So you have pain as a common symptom in most of the diseases as well. So here, because of the contractures or because of hypertonia, sometimes there might be a severe musculoskeletal pain. So baclofen, which is a centrally acting muscle relaxant, or any other muscle relaxants, would be of great help. So they should be used liberally, but you should kind of assess the pain and the nature of the pain that the patient is having. So if it is not a muscular pain, you should not give a muscle relaxant in that case. So you should give analgesics according to the type of pain that the patient is suffering through. Analgesics again, if and when required, analgesics should be used liberally. And can you just excuse me for a minute? Just 1 minute. Analgesics should be. Sorry. So use of analgesic should be done appropriately according to the type of pain that the patient is going through. So can you tell me what are the potential types of pain that a patient with any neurological disease may have? One is musculoskeletal pain. What are the other type of pain that the patient might suffer through?
Pain due to debilities like pressure sores.
Pressure sores. Okay, so that would be a nociceptive pain. Yeah, we can classify that as a nociceptive pain. Okay, musculoskeletal pain,
Yeah,
nociceptive.
they can have bladder spasms.
Bladder
bowel
spasms.
spasm.
Okay. Okay, spasmodic. So that would be what do you call it? Bladder pain. Okay, so vesicular pain basically it could be
Nociceptive. Vesicular
visceral.
nociceptive.
Yeah. So nociceptive, somatic, and visceral. Yeah.
And any infections also.
Yes. Okay. You have your neuropathic as well. Contractures. So I think contractures would come under musculoskeletal. Anything else? Neuropathic pain can be peripheral or central. So we might have to do that. Sometimes, do you think vascular pain may come up in patients with CNS disorders? Would they? So supposing because of prolonged, what do you say, prolonged bed-bound status of the patient, sometimes the patient might develop DVT or thrombosis. So those might sometimes lead to vascular pain. There's not, if the pain is severe enough and not getting relieved with your regular analgesics, certain analgesics which would be specifically helpful in vascular pain might have to be used. So can anyone tell me for nociceptive, somatic, or what kind of analgesics would you prefer?
Acetaminophen.
Okay, so you basically go according to the step ladder. Will that be in
Yes. Yes.
Yeah, so you'll use your step ladder, sorry, step ladder for the nociceptive, somatic. Any for visceral, so basically it will be your acetaminophen, your NSAIDs, and your opioids, weak opioids or strong opioids, right? Anything specific for the visceral pain, visceral, nociceptive visceral? You someone mentioned bladder pain, right? So what would you give for bladder spasms? Any specific,
It's relaxants. Yeah, muscle relaxants.
which specific, any specific agent for bladder spasm? Sorry.
Rolitin.
Yeah, or sometimes, you know, even oxybutylin and those can be used as well. Sometimes, not always. It will not maybe be useful every time, but it can be tried. Then for neuropathic, yeah, Urispas. Anything specific for neuropathic pain? What are the potential options that we have?
Gabapentin and this
Gabapentin, right? Yes, gabapentin. You have your SNRIs, SSRIs.
SNRIs and
Yeah.
yes, yes.
You have the whole list of antipsychotics that can be used. You have your tricyclic antidepressants as well. So Yeah, pregabalin, yes. Anything specific that can be used as a rehabilitative measures for neuropathic pain? Like, so you can have your hand and foot syndrome, like a lot of tingling, numbness, or burning in the palms and soles. So anything rehabilitative you can think of. No, I'm not talking about medications. I'm talking about specifically rehabilitative measures. Physiotherapy, B complex, yes. Physiotherapy, what in physiotherapy? Like, so you have something called as desensitization techniques. So what they do is that because those hand and foot syndrome, like peripheral neuropathy, is kind of very sensitive and painful. Like, so even touching is painful for them. Like, let alone putting pressure or doing some work. So it's kind of very painful for them. So what they do is some, they have different textures which they use on the palms and the soles to slowly desensitize them to that effect. So I've seen this being used in chemotherapy-induced peripheral neuropathy, but I'm sure it can be extrapolated to rehabilitative measures in CNS disorders as well. Neurostimulation, sorry, yeah.
Ultrasounds for stimulating the
Yes.
physiotherapy, may they use that?
Yeah, they use that. There are different textures from soft to a kind of a rough one. And they do it, I think they have to do it every day and they teach them how to do it. So that is pretty helpful. We can even use lignocaine patches. You get lidocaine 5% patches. So you can put it on the dermatome and it has a good effect on the neuropathic pain. Just needs to be remembered that it is 12 hours on and 12 hours off. So you need to remove it after 12 hours. Otherwise, there are certain skin reactions. So that is another very useful medication for neuropathic pain. Anti-epileptics, I'm sure everyone knows. You generally nowadays, Levera is the preferred one. But there are a whole bunch of anti-epileptics which can be used and it should be yes, reflexology. Yes, that can, I think that would be covered with your physiotherapy as well. Yeah, I think it is included in physiotherapy, but I'm not sure if it's a different one, then I'll have to find out about that. Now, do you have any comments on nasogastric insertion or PEG insertion or PEG feeding for patients with neurological disorders? Should it be done? Should it not be done? Or when should it specifically be done and when you should not consider it or remove the NG tube if already in place?
Should be done and should be done early.
Yeah. Yes, so correctly you said that it should be either done early on in the disease trajectory or it depends on the general condition of the patient. Yes, so if there is no consent anyway, they will not do it. Patient's choice, yes. Supposing
Passing a NG tube, does it increase the chances of aspiration?
So there are mixed reviews on that. Certain people say that NG tube would reduce the chances of aspiration, but other people say that PEG tube is preferred over NG tube because since it crosses your gastroesophageal sphincter, the NG tube would keep it open. So PEG feed would be the one which prevents any aspiration, but NG tube might sometimes leads to aspiration as well. So there are kind of mixed reviews, but it depends. Like PEG insertion is a bit more costlier affair in the country, in our country and in our place. So depending upon the affordability of the patient, you can go for PEG insertion, but NG tube is still the preferred one most of the time.
Widely is recommended during crisis situation. Like if you put it, actually increases the disability of the patient. And again, it is a very tricky idea. You have to discuss with the family.
You have to discuss everything with the family. You have to teach them proper care of the family, proper care of the NG or PEG tube. You have to kind of tell them when you need to change it. If it's like a long-term thing, then when to change it, how.
I think at the same time, patient can pull out the NG tube anytime by himself. That's
They
also
can
another.
actually. Yeah, so all the logistics needs to be taken in account, and sometimes, not sometimes, many of the times, it so happens that the tube is inserted at the very late stage. So sometimes it can be perceived as kind of like a very invasive procedure in a patient who might not benefit from it. So that also needs to be taken into account, that if it is at the very end, especially when you have your the prognosis is less than few weeks or maximum to a month, would you really want to put in an NG tube? Because there will not be any added benefit other than just prolonging their suffering at this point. So would you want to, or should you put in the NG tube or a PEG tube at that point? So that all needs to be taken into account as well. Then coming to speech aids, again with the rehabilitative measures, especially with patients with aphasias, we can use certain speech aids to facilitate communication with the patient. So there are a lot of speech aids in the form of those laser pointed ones where they spell out what they want to say. You have your computerized ones, if the patient is able to type in, and also the patient can type in. You have your like a simple yes and no question, so that the patient can answer, like blink once if it is a yes, blink no if it blink twice if it's a no. Those simple yes and no questions can also be used, but again it depends upon the availability in the local area. So you need so we have nowadays have super specialist physiotherapists who are particularly trained in management of neurological cases. So you'll need to get in touch with them, or you'll need to have a person who has a specialization in neurological physiotherapy. And if they have certain measures for speech aids or anything that they can do for vocal rehabilitation as well, you might want to consult your speech and swallowing therapist. They can help in both the swallowing part as well and the speech part as well. So having a speech and a swallowing therapist is also a useful team member. Any questions till now? Okay, so moving on to the cardio.
Wait, just a second. What all various muscle relaxants could we use in CNS management?
So baclofen is a central one that would be very effective. Other ones you can use is your you have your peripherally acting muscle relaxants, like you have your thiocolchicine, you have your chlorzoxazone, so all those in combination with NSAIDs or paracetamol or even aceclofenac. So basically you'll have a combination of those doses. So you can use either those, whichever has more effect on the patient. And plus you give your physiotherapy along with the muscle relaxants. So peripherally acting muscle relaxants can be your first line. And if that is not helping, then go to a centrally acting one.
Okay, so you mean to say we can use it for contractures and stiffness?
Yes.
Okay.
Yes.
Along with physiotherapy.
Along with physiotherapy.
Yeah. Thank you.
Now coming to the cardiovascular system, so basically it will be your heart failure, congenital heart diseases, and the isomerization of those heart diseases. Then commonest symptoms would be breathlessness, chest pain or pain, heaviness, palpitations, which often be perceived as anxious or anxiety in the patients. Then you'll have your peripheral edema, cough is there. Sometimes hemoptysis might also be present. There's a lot of fatigue and sleep disturbances because of the pain or the breathlessness. Coming to the rehabilitative measures, as I said, rehabilitative measures is across the board. So any breathing techniques or physical exercises or spirometry or anything can be used to relieve the symptoms, can be would be beneficial here. Now coming to the analgesics, opioids would be used here very often. Can anyone tell me what are the benefits of using opioids, more specifically morphine here?
Pain management.
For pain management, yes. Anything else? For dyspnea, very good. Anything else?
Venodilatation, causes
Yes.
venodilatation, and
So the preload on the heart
heart is
is
decreased.
reduced. Yes, correct.
Reduces the stress of that dyspneic feeling.
Yes.
That's most as this thing that when
So,
symptomatically they feel much better.
yes, exactly. So what happens is the opioid in like morphine for dyspnea basically will take out the will kind of abut the sensations of breathlessness going from the lungs and the chest wall to the brain. So that is abutted. Plus, it would have some anti-anxiety measures as well. Like, so basically act as an anxiolytic also. Plus the preload is reduced, and for pain management. So it's multiple ways in which it is helping in managing the symptoms. Diuretics, as we all know, it's one of the common drugs that is given for heart failure. So usually, and it will also help with the peripheral edema of in the patients as well. Now, for palpitations, certain books mention use of beta blockers. Do you agree or do you not agree with this? Or should it be given or should it not be given? And what would you prefer for palpitations in this case? Yeah. So that I'm not exactly sure when it is not to be given. I'll read up upon that. But it says that if the so basically the increased heart rate kind of compensates for the overall decreased ejection fraction, right? So basically that is what is happening. So some say that it might be detrimental to give those beta blockers. So it's kind of a debate, but I'll find out the details about this and I'll revert back to you guys. Oxygen support as and when required, and oxygen should also be used as a drug. And it should be used judicially. So it should not be given in patients who do not require oxygen. So sometimes oxygen is put in just for that that effect that air is blowing on the face, and that's how it helps, because the saturation might be normal even before putting in the oxygen. So in that case, a handheld fan or non-pharmacological measures for breathlessness might also be useful. So those should be used very effectively. Then coming on to the respiratory diseases, here we have our end-stage COPDs, end-stage ILDs, you have your cor pulmonaire, and you also have your pulmonary embolism. Now, the symptoms kind of overlap with that of cardiovascular. So you have your breathlessness, weight loss, fatigue, delirium. You might have palpitations. You might have hypoxia-induced headaches as well, and generalized pain also. Again, rehabilitative measures. Opioids here also have a similar action. In the sense that it would kind of relieve the breathlessness through anti-anxiolytic and your reduced sensation of breathlessness. And also the pain because of excessive heavy breathing will also be relieved with opioids. Diuretics, anyone knows why I have mentioned diuretic here? And in what form?
Case of pulmonary edema, fluid overload status.
Okay. Anything else? So parenteral right-hearted failure. Yes. So cor pulmonare, it will help in cor pulmonare.
Patients in heart failure, it is helpful along with ARBs and beta blockers.
Yes.
They have been shown to they decrease morbidity and mortality in such patients. Decrease
Yes.
incidence of hospitalization too.
Yes, correct. Anything else? Anything else that for breathlessness, specifically for breathlessness that mentioned? So there are studies for nebulization with furosemide. Basically, it helps reduce the overall edema in the bronchial tree, which helps in breathlessness. Now, there are very few, so we had tried using it for patients with breathlessness. Very few had actually responded well to it. So it's kind of a dicey situation. You can try it and see if it's working for the patient, but it most of the time may not. But it is an important drug to have in our toolkit. Then dose and frequency, it was 20 milligrams injection that we have. That was nebulized through like a nebulization machine. Frequency, we gave it at like a stat dose. If it's responding, then we were like, use karna 2 baar din mein, aise. It was not a fixed dose. So we were basically going by, if it's working, then use it. Otherwise, don't use it. Opioid dose as anti-anxiolytic in case of breathlessness. So so I would not use opioids as an anxiolytic agent. If the patient is not previously on any opioids, I would start by a very low dose of 2.5 mg, maybe TDS or QID, depending on the requirement of the patient. Its anxiolytic effect will come along with its effect for breathlessness. So, but if you need an additional anxiolytic, then I would want to add maybe a benzodiazepine for the patient instead of increasing the dose of opioids directly, because I don't want them to land up with opioid intoxication there. Yes, nebulize, yeah, COPD, and it was mostly for COPD, not for ILD. Yeah. No. Directly, the injection was put in the nebulization machine. That the container we'd put directly 20 mg. N-acetylcysteine. So basically, it will help thin out the secretion. So, and it also has an antioxidant property. So that also helps with your overall breathlessness. And it's quite helpful. It is quite helpful for, especially with patients who have a lot of secretions and a lot of thick secretions. So it kind of helps you thin out those, and so that they cough it out properly. So an acetylcysteine along with your chest physiotherapy helps very well. So again, N-acetylcysteine nebulization, the ampules that you get, so directly break the whole thing in a nebulization container and nebulize it. Oxygen support, again, should be used as a drug as and when needed, and should be kind of titrated appropriately as to the minimum requirement of the patient. Antipsychotics might, so sometimes the patient might land up with delirious in delirium or in an agitated state because of multiple reasons. So antipsychotics wherever required. Any specific antipsychotic medications for delirium that you can think of? Haloperidol. Anything else? Haloperidol. Anything else? You have your olanzapine as well, that can also be used. You have your quetiapine, which can be used. And yeah, these three mainly. If not working, then you might go on to some other antipsychotics. Steroids, as you know, I think in management of COPD and in management of ILD, it is helpful not only to reduce your inflammation, but also helps with the secretions as well. So that can be used wherever required. Budinase and levocetirizine, specifically for what, sir? Budinase for and levocet for what exactly are you saying those for? So nebulizations can be used wherever you feel that. So like supposing the breathlessness is because of some exacerbations and it is responding to your usual ipratropium and budecort, then those should be used along with it. This I'm talking about, which is the breathlessness or the pain which is not responding to your usual management. Allergies, yes, wherever required, you should use that. In case of dry cough, how about codeine? So the thing about codeine is that eventually it gets converted to morphine and then acts, then has its action. So since you already have morphine, why go for codeine? And so there are, as you know, there are fast metabolizers and slow metabolizers. So basically, if it's a fast metabolizer and you give the high dose, they might end up with opioid toxicity and intoxication and not even know why it is happening. So because we do not do the genetic testing before giving codeine, like, so abroad they usually do the genetic testing before giving codeine specifically. So if you don't get morphine, then yeah, then that is an option. Then maybe start off with like a very low dose of that as well, because eventually it will be converted into morphine. So maybe start off with a half tablet before going on to the whole tablet. But titrate it as you go along. Yeah. Any other questions? Okay. So coming to the hepatobiliary, basically we have your end-stage liver diseases. So it might be because of cirrhosis or permanent liver failure. The commonest symptoms here would be your nausea, vomiting, fatigue, weight loss, and all the signs of liver failure that you have. Now, rehabilitative measures, again, we have said. What about the antiemetics? What would be your antiemetic of choice in patients with nausea because of raised, let's say, bilirubin, deranged LFTs, basically? So what would be your antiemetic of choice and why? What do you normally give? Like suppose a patient with deranged LFT.
Fully available.
Sorry?
5-HT3. Planocytone. Ondansetron is a very short-acting drug. Planocytron is used. Yeah, NK1 antagonists are used.
Specific reason why you're giving 5-HT3 and why metoclopramide also. Metoclopramide also can be used, but why specifically why?
Metoclopramide.
Or ondansetron.
Electromagnetic होता है metoclopramide, but the problem with this is कि it can cause extrapyramidal side effects.
Yes.
And
Okay.
some for patients. So
Why ondansetron then? Why 5-HT3?
no, not ondansetron. Ondansetron is a very short-acting drug. It just acts for 4 hours
Or
duration.
okay.
You have to repeat
Yeah,
them.
5-HT3. Why 5-HT3? Any particular reason why we are using 5-HT3?
They are available, easily available. They are long-acting. Means if you use piracetam and all that, they act for about 3 days. But
Okay.
NK1 agonists are used basically for these patients,
Okay.
those who are on chemotherapy.
Yeah, sorry, NK1 is basically more specific for chemo-induced nausea
Yeah.
vomit.
But their
Yeah, so
availability is also, they are costly and availability is also an issue.
yeah. So here in like, if you know that the cause of nausea vomiting is because of deranged liver functions, like it's the liver that is causing your nausea vomiting, you would go for any medicine which is centrally acting. Any centrally acting medicine would work. Centrally acting in the sense which crosses your blood-brain barrier. So do you have a question? Swarnendu, I'm sorry if I'm mispronouncing your name. Okay. So basically any centrally acting medication. So metoclopramide also crosses your blood-brain barrier. So that would also help in hepatic nausea vomiting. Ondansetron or any other 5-HT3 because it crosses your blood-brain barrier. Any other medicine that you can think of which can be used for nausea here? Yes. So 5-HT3 or ondansetron with opioids. So with certain opioids, it is not good to be used. For example, tramadol and tapentadol, because it has kind of what do you call it, antagonist properties. So this is 5-HT3 antagonist, and you have your serotonergic effects of tramadol and tapentadol. So even when you're giving injectable tramadol, ideally you should not give ondansetron along before tramadol because antagonist properties. So either metoclopramide or go for haloperidol in that case. So and I said the answer. It's basically haloperidol. It is an D2. It will act on your dopaminergic receptors and prevent nausea. So anything that works on your chemoreceptor trigger zone. So those would be helpful. Yes, it is also a prokinetic, so it would help with your constipation as well. Correct. Dexamethasone generally works in can be given for nausea vomiting. The mechanism is not clear, so it may or may not work, but it should have an effect on your nausea vomiting.
What about promethazine and that class of drug?
I am not sure. It should be helpful because since it's centrally acting, it should be helpful, but I'm really not sure about the dosing in hepatic patients. So you need to be careful about that. I've written sertraline over there. Can anyone tell me what might be the symptoms that I've said that for? I should actually change this.
Because of the jaundice which they have.
Yes.
Itching and associated, also maybe taking care of the nausea, vomiting also.
No, so sertraline specifically for your
Ascites.
pruritus. So it's not for ascites. Ascites you will have to either. So if it is not a malignant ascites that the patient is having, your diuretics might be beneficial in those patients. If it is a malignant ascites that the patient is having, a combination of diuretics or steroids. So DEXA might be helpful in those patients. There are even studies which says that intraperitoneal injection of dexamethasone post therapeutic paracentesis is helpful in prolonging the time between the two ascitic tapping. So that can be. Sertraline here I've specifically said for pruritus. So because of the bile salts, the itching that you have. So sertraline is the first line treatment in managing pruritus, and it works wonderfully. So 12.5 mg HS dose is helpful, absolutely reducing the itching sensations in those patients. Then we talked about metoclopramide, which is a prokinetic, and we'll have to give laxative as well because there's a lot of constipation in patients with deranged LFTs. So any specific reason for using a specific laxative, and which laxative would you think of? So there is a risk of serotonin syndrome, but I don't think we're giving it at a dose which would cause that many that much of, it might not lead to serotonin syndrome because the dose that we are using is not that high. There is a risk, so you'll have to keep a watch out for the symptoms of serotonin syndromes. Bulk forming, okay. Lactulose, yes, lactulose would be preferred laxative here, or bulk forming. If bulk forming along with the prokinetic, then along with the stimulant, you'll have to give.
Softeners like lactulose or glycerol, or you can even use this stimulants like bisacodyl, and
Yeah.
or you can use a combination of both.
Yeah.
The
Yes.
softeners and stimulants.
Yes. While
like that.
lactulose is specifically said for liver failure. Ammonia. So basically
Ammonia.
prevents the absorption of ammonia. Yeah. So, yes, it's in the management of your liver failure, right? So if you have a so management of liver failure, you would basically give a laxative, or more specifically lactulose, to prevent the absorption of ammonia that is being formed in the gut. So the dose should be approximately what they say in the textbook is 30 ml thrice a day, or till there are 3 to 4 loose stools per day. So you should maintain that 3 to 4 loose stools per day. And then you have your what do you call it, antiemetics, which if required, antipruritic agent if required, and you give your L-ornithine, Lola, that is L-aspartate, L-ornithine if the patient is affording. You give your antibiotics, gut antibiotics, so that the formation of ammonia is reduced. So either initially they used to give Metrogyl or Neosporin, but nowadays they give rifaximin specifically for because it does not get absorbed systematically. So antibiotics to just prevent the formation of ammonia. So those would be your management. And supportive measures. So supportive measures, basically I said about, the therapeutic ascitic tapping if required, stockings for the edema if required. So all the measures which can be beneficial to the patients can be used. Coming to the renal disorders. So we have your, yeah.
Or pruritus. Is it the
Yes.
first line of choice?
Sertraline is first line of choice. Second line is dapsone, and third line is your ondansetron. So ondansetron also works for pruritus here.
Sertraline is the first line of choice.
Yes,
Ondansetron comes as-
Yes.
Thank you.
Any type of specific diet in liver failure. So according to the latest literature, look, so previously we used to say that a vegetarian diet is preferred over a non-vegetarian diet. Recent studies have said that as long so there should not be any energy deficit for the patient. So the patient should not go hungry for more, or rather he should not starve for more than 4 to 6 hours. So there should be frequent meals that are given. So every 4 hours, the patient should eat something or the other. And there is no specification of whether it should be a completely vegetable or vegetarian diet, or can be a mixture of non-vegetarian food as well. So that was not specified, but basically the rule now states that the patient should not be starving for more than 6 hours, maximum 6 hours. So something or the other should be given to them at a 4-hourly basis. Plant-based protein is preferred because it's kind of easier to digest, but egg whites are also acceptable. And non-vegetarian or meat basically can be given maybe once or twice a week, depending upon if the patient is tolerating it or not. But they've not completely specified that you should not give lean meats or red meats or whatever diet for liver failure. Ideally you should not be giving, because it gives an extra strain on the liver just to kind of detoxify it. But that's kind of controversial, because you don't want, like, if he has been like a chronic alcoholic and that is the reason for his liver failure, you can't abruptly, you should abruptly stop the alcohol, but you'll have to be well prepared to manage the withdrawals as well. So you need to take both of the things into account and then manage the patient accordingly. Depends upon how much quantity and if that is the reason for the disease. Anything else? Okay, so coming to the renal disorders, so end-stage kidney diseases, which can be because of hypertension, diabetes, or your glomerulonephritis. So the symptoms again overlap with those of hepatic. So you have your nausea, vomiting, you have your decreased appetite, you have your fatigue, your decreased urine output, and thus you have your signs of fluid overload. You have pruritus over here as well. You have your muscle twitches and cramps and sleep disturbances. So any thoughts on nausea, vomiting here, renal nausea, vomiting? What is the cause for nausea, vomiting in patients with renal disorders? Uremia. Yeah, so it's basically uremia. So again, it will be anything that is centrally acting, right? So your 5-HT3s would work, your metoclopramide will work, your D2 antagonist. So haloperidol will also work. So anything that is centrally acting. So a centrally acting antiemetic would be the drug of choice. For decreased appetite, anything specific that you can think of? Would you give an appetite stimulant in this patient? Let's go in that way. Would you want to give an appetite stimulant in this patient? So you can give an appetite stimulant. It may or may not have any effect on it, on the patient. But you can advise them for small frequent meals so as to not induce nausea or induce that sense of fullness which leads to discomfort. So ask them to have small frequent meals, and how much ever they can tolerate at one go. So, and you can, according to the amount they are taking in, you can decide the frequency or the time duration, time gap between the two meals. Now, fatigue. So in any in any system, the fatigue is generally managed by your rehabilitative measures, right? Light exercises or distraction therapies, or psychological interventions might sometimes relieve fatigue. This is mostly because of the, we call it chronic fatigue syndrome, like fatigue of chronic diseases. So because of the disease processes, there are a lot of inflammatory changes that occur in the body, which leads to the fatigue in the patient. So the fatigue is also kind of multifactorial. So there's not a specific medications that are given for fatigue in any situation. So it's mostly your rehabilitative and psychological measures that can help with your fatigue. Now coming to again, the laxatives would be your lactulose, which or your stimulant and men. Yes, so because of the low hematocrit also, and the anemia is basically because your erythropoietin is not getting formed and all those. So erythropoietin can be given as injection, so which helps with anemia, which might help in relieving the fatigue. But again, like how frequently and how much because that injection also is a source of discomfort for the patient. So again, it depends on how and how much and when and whatnot. So those laxative again, which either as you said, lactulose or bulk forming with a stimulant, so that they are not constipated, and supportive measures. So those will go on hand in hand. Just would like to add in here about the if the patient is on, let's say, hemodialysis, right? The patient is on hemodialysis. So when do you feel is, or rather, do you feel that at one point it would be better to stop the hemodialysis? Or when do you feel that would be an appropriate time to counsel them regarding maybe stopping the dialysis? It can be peritoneal or hemodialysis. Any experience with that? Anytime the patient has said that bahut ho gaya, bas ho gaya. Anyone?
Failed fistulas, access sites when they and when a patient becomes completely dependent on dialysis, there's no residual urine output. In between dialysis, also he starts becoming symptomatic.
Yeah.
Where this
urine output is not increased after dialysis.
Yes. So you both are absolutely correct. So feeling weak after each dialysis. So I had this patient who was on initially was on twice weekly maintenance hemodialysis, but it had increased to thrice a week hemodialysis. And what she said was that I am not symptom free even for 2 days after the hemodialysis. So what would happen is that she would be, she would come to the hospital on the day of the dialysis, and she would be so distressed and almost unconscious by the time the hemodialysis was over, and she had no idea about how she reached home. She would sleep throughout the day. The next day she will feel a bit better for maybe half a day, and the symptoms would reoccur, and then the next day she had to go to the hospital again for the dialysis. So it kind of was like there was no benefit of doing hemodialysis because the quality of life was absolutely horrible. So the husband, along with the son and her, we sat down and we discussed, and we took the decision of just letting whatever happens. We signed a DNR, and so she passed away in 2 weeks after that, and it was a very peaceful death. So kind of needs to maybe kind of approach the topic of maybe it would be a good thing to stop the dialysis or whatever kidney replacement measures that are ongoing. Low ejection fractions. Yeah, so I think they would anyway not do the dialysis if the ejection fraction and the blood pressure is low anyways, and bleeding tendencies. Yes, so I think those would be the things that would be the contraindications for dialysis anyways.
So withdrawal issues of dialysis are basically, they are based on issues of symptom management, the decreased quality of life that the patient has, and the impact
Yes.
on progressive disease.
Yeah. So, when the so initially the patients would start off with like maybe once a week dialysis is required, and it would kind of gradually increase to twice a week to thrice a week, or daily dialysis. And some of the patients might not even be symptomatic during the dialysis or after the dialysis. They would just require the dialysis at that time. Like, my patient had a lot of symptoms even during, after, and before the dialysis. So sometimes the patient might not be that way. So then the symptoms would not be the reason why you're continuing with the dialysis. Like if you see that the patient's overall functionality is decreasing and is becoming dependent on dialysis, it is a good time to approach them about the nature of the disease, about the nature of management that they're giving, and the kind of quality of life that they're leading, right? So as you see the disease progressing, it is a good time to approach them about the need for, I'm not saying that they should withdraw it immediately. I'm just saying that maybe the need for more palliative care should be introduced at that time, so that they might have a chance to kind of process it themselves as well. So yeah, and not all will agree with it. So you just letting them know that that is also an option is a fair enough thing to begin with. Yes, ultrafiltration failure and PD. Yeah. So even peritoneal dialysis is quite painful for patients, and because it needs to the process is way longer than that for hemodialysis sometimes. So that also is kind of very irritating for the patients. Anything else? Encapsulating sclerosis. For what, sir? Like for what exactly? As the reason? Yeah. Yes. Okay. Shall we move on to the next topic? I would like to discuss that as well. So end of life care. So this was the pathway given by the Indian Society of Critical Care Medicine. So this is more specific for ICU patients. So, and as you can see, it's quite confusing as to what exactly is happening here. So the simplified version is that if the patient is coming in the ICU from an emergency department or a referred from a primary physician or the relatives have got them to the ICU, and you know that there is prognostic uncertainty, and you've discussed it with the rest of the colleagues that are managing the patients along with you, and there is a consensus that yes, there is kind of prognostic futility in further management, then basically what they suggest is that you should have a family meeting with all the stakeholders in place. You should kind of have a honest discussions with the patient and the patient / relative or / caregivers. You establish then the goals of care that the patient or the relatives have according to the wishes, preferences, and values of the patients and the family. Then consider withholding or withdrawing the life-sustaining treatment. Then give good end-of-life care for those patients. Have repeated counseling sessions with the family members, have good comfort care for the patient and the family, and bereavement support as well. And in the whole process, you basically document everything that is going on. Again, it's important to remember that this is not set in stone, that once the relatives make a decision, that is it, that is final. That is not the case. They have complete right to change their decision at any given point, and it is important to let them know that they can change the decision at any point of time in the course of illness. So that this is the simplified version of your end of life care process or management. So as you can see that it's a long road ahead, and we have to kind of manage all the barriers that are there, not only from the physician side, but also from the patients or the relative side, and the complexity of the disease trajectory that is involved in non-oncology, that also is pretty difficult to manage. So thank you so much. Any questions?
Thank you very much, Rutula. As you mentioned, it's a very wide topic, because you have, as you have gone through system-wise, it is a big thing. And someone has raised their hand. Can you unmute and speak if you want to ask something before we go ahead with the case presentation? Dr. Biswas?
Dr. Swarnendu?
Not responding.
Might be
So we'll, as you have mentioned, no, it's a thing, important thing, I would say. Every system can have patients who may need appropriate palliative care. Like, take on important things, I would say, that road to death, no, that chronic illness graph is something to have in mind. And they never get back to that, to the baseline of how they started this episode of not being unwell. So that is one important thing I would like to take all of you to put some interest and see that and convey in some form or other to the patient and family about it. Because that is something, no, that is where awareness can be raised. Not that we are not going to do anything. That is how the system functioning happens. Because of the multiple comorbidities, their baseline itself is low, and every episode of being unwell, they recover. But you yourself compare and see. For example, if they start at 50%, it is not even 50% at the end of that episode. So that is something to be borne in mind for us in the first place, and then conveying for them to know, and then accordingly, if people will understand. And we've all had a nice discussion during the session itself. Anything else you want to ask, we'll go ahead with the case presentation and come back. Anup, can we have the case presentation?
Yes, ma'am.
Should I share my screen or will you share it?
I can share it from my side. Yes, ma'am.
Go ahead, Dr. Parvati.
Yeah. Thank you very much. Good evening, everyone. My name is Parvati. I work with Medicine Sans Frontiers. It's better known as Doctors Without Borders. And while I have been a clinician for the past 10 years, at the moment I'm running a course called the Global Health and Humanitarian Medicine course. But what I want to take you through is a case which is actually a little dated at this point of time, but it is one of the cases which affected my practice of tuberculosis over the years. So the case presentation is about palliative care and incurable tuberculosis. Next slide, please. So this is a 30-year-old male patient, and the diagnosis is well-controlled HIV stage 3 and consistently positive drug-resistant TB. I'd like to mention this is only pulmonary TB. Next slide, please. Presenting complaints. At the moment when I'm presenting, the patient complains of breathlessness, which is worsened on lying down, chest pain, and paroxysmal non-productive cough. These started 6 months before the latest treatment regimen for TB. So the latest treatment regimen was 1 year before, and these symptoms started 6 months before that, but it has worsened over the past 2 months. Next slide, please. So the history of illness. The patient is a known case of pulmonary tuberculosis. He was first diagnosed with drug-susceptible tuberculosis in 2007, but the outcome was not evaluated. That means that we don't know what the outcome was. He was then started on drug-resistant TB treatment in the private sector. The persistence profile is unknown. From Feb 2012 to April 2013, he was treated by the RNTCP. That's what it was called then. Now it's called NTP, which is the National Tuberculosis Elimination Program, for pre-XDR TB that's resistant to first-line TB drugs and fluoroquinolones. In April 2013, he was referred to the NGO clinic for treatment with bedaquiline. This was when bedaquiline was available under compassionate use from Janssen, though it is now part of the first-line treatment for MDR TB, but this was quite a while back. At this time, he was resistant to first-line TB drugs, fluoroquinolones, and all second-line injectables. So he was started on a new regimen which had linezolid and bedaquiline, but he remained smear and culture positive until 2014. So he had also developed some level of hearing loss due to kanamycin and GI side effects, severe gastritis, and he had intermittent diarrhea, probably because of his meds. He was also HIV positive. This was diagnosed in 2012. However, he was adherent to his antiretrovirals and the HIV is well controlled. Next slide, please. So his height was 171, weight was 41 kilos. BMI was very low, 14.2 kilograms per meter square. Pallor and clubbing was seen. The pulse was regular and rapid, 102 beats per minute. The cardiovascular system findings were within normal limits. Respiratory system, 30 breaths per minute with accessory muscles working. Crepitations and wheezing, I didn't mention it, but it's over the upper middle zones, if I remember right. Increased egophonia and vocal resonance, and there's some asymmetry in lung expansion. The abdomen is soft, non-tender, no organomegaly, and the CNS is alert, conscious, normal reflexes, and all findings are within normal limits. Next slide, please. So investigation. So his oxygen saturation is low, 92. His hemoglobin is 9 grams per deciliter. WBCs is 550,000. Platelets is 160,000. ALT, AST was 40, and ALT was 40, and AST was 41. Creatinine was 0.9. CD4 was 576. As I said, he was doing quite well on his antiretrovirals, and HIV viral load was undetectable. ECG QT interval was 450 milliseconds. You will see when you look at the drugs that he was on. And the X-ray showed fibrocavitary lesions bilaterally in the upper and middle zones. The sputum was consistently smear and culture positive for acid-fast bacilli from treatment initiation to date. So the treatment, he was on amikacin and levofloxacin, cycloserine, linezolid, clofazimine, and bedaquiline was stopped at month 6 because at that time you were giving bedaquiline only for 6 months and continuing the rest of the drugs beyond that. He was on tenofovir, lamivudine, and nevirapine for his antiretrovirals, and he was on various concomitant medications, which included multivitamins, antiemetics, and antacids. Next slide, please. So psychosocial aspects: unmarried, no addiction history, worked as a laborer until 2012. He had studied up to class 10, and he had good family support from his father and sister. Next slide, please. TB treatment, as I said before, No new drugs or regimens were possible at this point. There wasn't, Delaminate wasn't even available in India, and we weren't even talking about imipenem then. That being said, at this point of time, even if this patient came to be now, there isn't much we would be able to give him because he's used practically all the drugs. ARVs, tenofovir, ARVs and concomitant medications are mentioned earlier. Next slide, please. So the patient's main concern was breathlessness with symptoms matching the description of air hunger. He also complained of paroxysms of non-productive cough, which caused chest pain and increased breathlessness when they happened. Next slide, please. So the summary, he's an HIV positive patient co-infected with incurable drug-resistant tuberculosis, consistently culture positive with a salvage last chance regimen and no further treatment options available, cachexic due to advanced TB disease and being unable to eat due to lack of appetite and GI side effects, ineligible for surgery due to bilateral extensive lesions. There would have been no pulmonary reserve for surgery, and the patient is in distress due to dyspnea. Next slide, please. So the discussion points. Programmatically, we have to declare treatment failure because this is obviously not working for him. So there's intolerance to TB drugs. There's no really effective regimen left. So we can debate the value of continuing the current regimen or giving him any regimen in the future. Infection control, especially for caregivers, keep in mind he's smear positive. At this point of time, he was 2+, so he's quite infectious and it's pulmonary TB. And asymptomatically. So relief from dyspnea, we have to give him access to an oxygen supply, whether it be through oxygen, though his demand was quite high, so a concentrator would probably make sense. And perhaps, well, at that point of time, it was very difficult to get opioids, but that would be the best. Pain management, though, at the time which I'm discussing, which was when we were declaring treatment failure, that wasn't so severe. Nutritional support and hospice care, which is hospital-based or home-based, depending on patient's choice. Psychosocially, the psychosocial aspects are actually quite considerable over here. Disclosure of prognosis, support of patient and family after disclosure, shared decision-making regarding treatment decision, specifically like declaration of treatment failure, and the decision possibly to stop medication after that. Financial support for the use of oxygen cylinder or concentrator. Even if we don't give cylinders, concentrators significantly increase electricity bills. Respect for patients and families' beliefs and values at end of life, and support to the bereaved family after the patient's inevitable passing. Next slide. Yeah, that's it. Thank you.
Thank you, Dr. Parvati. It's an extensive, multi-pronged case. Only one thing, first thing came to my mind is, nowadays, where exactly is this patient and where do you practice?
So, ma'am, this is actually quite a while back, and this patient has also passed away maybe a year or 6 months after this. At that time, I was practicing in Mumbai.
Okay, because there are something called as reach centers we used to have in Chennai, which are exclusive for these tuberculosis. They are government-based centers which they will support these type of patients in other places. So, like to know that whether because we are getting to a stage where we are telling that no, nothing. Him being positive all along is something which is showing that he is not responding.
Yeah, ma'am, we have these patients in Mumbai even now. I've talked to my colleagues there. We have not found any options for palliative care for these patients.
Yes, because see, resistant, multi-drug resistant, basically he is. Isn't it? You have tried.
Yeah.
So, And I will pass it on to Rutula. What is that she wants to take us through? And
So, any specific problems you had? I'm not, be it symptom wise or any social problems specifically you faced during that time?
So I think this was and patients like this continue to be our most difficult patients. One is that there's considerable difficulty in access to opioids for most such patients, and which is something which is very important for them. And also oxygen, as I said, uh, oxygen concentrators are very expensive electricity wise, and these patients usually are patients from the lower socioeconomic status, and therefore it becomes difficult for them. So then what we try to do is connect with trusts or those kind of people who can help support the cost of the electricity bill. That's one. The second part is disclosure of prognosis. It's quite a long procedure. Very often people don't believe it, go to some doctor or the other who says that, no, we can give you something. It's also very difficult to explain to people that they should stop TB treatment, and because most people see TB as a curable disease, but if you are resistant to everything, then it becomes a problem. And then I think one of the most important things is that most of these patients and families want to pass away at home, but infection control in a lot of these places is very difficult to achieve. And the only barrier, so to speak, the caregiver could use N95 masks, but then they're very expensive for the caregivers. So I think like almost every part of the discussion is difficult, and we really don't have any answers for these. But I think the one thing we could work on, and which is doable, is access to opioids that at least manages the symptoms.
Yeah.
Go
Yeah,
ahead,
go ahead.
Rutula. Then I will.
Many of for the opioids specifically, there are, I'm not sure if it's, where are you currently based? I'm sorry.
So,
Mumbai, she said.
Ma'am, I'm not currently working with the project, but I visited them recently. So how they do manage these patients now is they have one colleague who works near KEM who prescribes opioids to these patients. But even then, they end up sometimes having supply issues and those kind of things. So we do have some options, but it's not consistent, and it's only one option. So there's no backup option, so to speak. And this is not even, it's definitely not available through the MOH, though we work with Ministry of Health patients. The government system, we're an NGO. So we have worked with the government system, and we refer these patients to someone whom we know, but there is nothing in place for in the public health setup for such patients. It's individual facilities or individual district TB officers who are committed, who find solutions. So it's not a systematic solution, it's very individual driven, unfortunately.
So there are a couple of distributors who are available who provide specifically opioid medication. So be it just morphine or fentanyl as well, sometimes buprenorphine as well. So you can find out in your area if there are any distributors like that. So what they do is they generally either have like a store where they give medications, or like a pharmacy, or they do home delivery for the medications as well. So all they need is like a prescription from you, either in triplicates, or they have their separate prescription pad in which they take all your details as well. And then you just provide the medications for the patient. So if you're still in Mumbai, there is one that I know of. So in case you want the number, then I can.
Yes, please. I'll pass it on to my colleagues.
Yeah. So that is one potential way of doing it. Another one is, as you said, get in touch with the local district hospital, because usually government setups won't have opioid availability, but it's easier to get it there because it's like a government institute, so they have better connections with the health ministry and all. So you can work with the district hospital and or your health minister of the area or of the
Yeah.
of the local government, and make it more available. Or if you are attached to an institute, then you can get your hospital or pharmacy registered with the NDPS. So you can get the license, you can store it there, and that would be way easier to then, prescribe opioids when needed.
Yeah, ma'am, just working with the public health system, as you know, is challenging, especially since TB, like, people don't want to deal. The TB is OPDs outside the hospital because people don't want to deal with it. Yeah, so. But I take your point.
Yeah, so maybe and that'll be difficult if you want to include it in your TB program, like opioids for patients with in TB with breathlessness. So maybe that would be difficult to do, because then who is going to keep the account of how much is given and how much is not given? So in that case, it would be better to get the institute registered rather than the
Individual.
program. Yeah. So that would be a better choice. Yes.
You can contact Pallium also. That is what came to my mind.
Yeah, they help
Because
you
the
get-
regional coordinator might at least guide you where are the places available and things like that. So you can get in touch with Sri Priya, and we will have a session also. See, a couple of things I wanted to say. One is you will have a session on opioids in breathlessness when we cover respiratory system. So that use, dosage, everything will be dealt with in that also. And regarding procuring opioids, Dr. Parvati could see, ideally, as Rutula mentioned, for the, as you mentioned, TB, even wherever I've seen in Tamil Nadu, it will be an outside clinic. They won't come in. All those things are there, but we will refer them. So ideally, if it is any government setup nearby will help, or getting your center, like once you certify and finish this course, you can, your organization with your certification can obtain.
Okay.
So for that, you can contact Pallium regional coordinator.
Okay.
There is a regional coordinator for Mumbai.
Okay.
Sunanda. If I'm not wrong, Sunanda is the person who covers your region. So like that, we have, you can get in touch. So at least find out the ways and means of obtaining morphine so that it can be used for people who really need it.
Yes. Okay, ma'am. Thank you.
So, and then other issues, somebody else has also mentioned about crowdfunding. See, that's all, getting some contact with nearby
or NGOs
centers.
taken the help of NGOs specifically for HIV, TB patients. So they do a lot of fundraising for them as well. So for financial issues, help from such NGOs can also be, and any, if you have hospice care, you've mentioned hospice care, so, or hospital-based end-of-life care if required. So if you have facility in your institute or you have facility of an hospice care in your area, you can kind of have a liaison with them so that they know you'll be sending the patient, and you can even write down your plan of management for the patient, and they can just follow it over there as well. So kind of maybe like an MOU sort of a thing with so in case it's not an hospice care, if you have like a nursing home who is ready to take in patients with HIV and TB, or who have facilities to manage such patients, you can have an MOU with them as well, just so, and at a subsidized cost. So just so that it'll be an easier way to patient care. Yeah.
Because she said they are having many such patients. Better to anticipate and have a tie-up with someone.
Yeah.
Because if your center doesn't have the facility, at least to have some options available for them. Maybe is there any exclusive government setup for tuberculosis?
Yeah.
And especially HIV, some
HIV,
things are there.
yeah.
I
So,
mean,
and people with HIV can have all these. See, they
Yeah.
are more prone for all these, no?
All
So
infections.
it's interrelated. So
ma'am, I
something
think it's more
Mm.
TB, which is the stigma than HIV. So we explored all
Ah.
this, and then when you send someone to a hospital, we discussed starting an MOU, and these are practical considerations, of course. So when we discussed an MOU, like every time we send someone to a hospital, they say, "Oh, it's a TB patient, we should put them on treatment." But there is no treatment which is going to work, and it's just one of those things which is a never-ending discussion.
I know. That's why it's a catch-22 situation, I would say. And especially if him being positive all along, no? So basically, that's all. Ideally is to send them, Anup, can we come out of this screen so that, because it may be better off to have an open discussion that these type of patients are there, problem from their end, and you can have a tie-up with the either a government or somewhere where they deal with this tuberculosis. That is also, see, these are things worthwhile, because if you're facing many patients like that, anticipate these and then see how it can. So together, if something will work, maybe better off both for you. And as she mentioned, no, this is burnout for the doctor also. So you think of all these things and look at options which could be considered and dealt with in a better way that's possible. So getting in touch with NGOs, getting in touch with government setups, getting in touch with Pallium to find out see, at least if you find out where morphine is available, you can, even though you don't have, you can send, and slowly once you finish this course and things, you can obtain and store and have it in your place to dispense. So all these things to be taken into consideration. Young patient, isn't it? So
Yes.
To try to do as much as we can in patients' best. Okay,
Also,
anything else, anybody?
I'll
Go
just
ahead,
like
dear.
to so if you have a lot of patients, like similar sort of patients, you can even consider having an MOU with an separate, maybe like a medical officer appointed for such patients, who would direct those patients about the line of management, in the sense that since you're saying that there's no further need for TB medications or whatever, so he can then directly, okay, these are not for active treatment, these are for palliative care. So, and maybe have like separate 10 beds and separated somewhere in the hospital, so that the rest of them are not infected. So that can also be set in. It'll just take a lot of like groundwork
Extra, going out of your way. It's
yeah.
not an easy thing, Dr. Parvati, definitely not. Both time and will be a challenge. That is where you can use the help of Pallium. Like the regional coordinator might know someone, because she's been working there. She is in Pune, but she covers Mumbai, that region, Sunanda. So she might have some input. So you need a lot of things, lot of effort, lot of time, back and forth. Many things will be there. So obtain all possible support and then move forward. Rutula, there was one message in the chat to
Yeah, I'm just sharing the
share.
number. Yeah, so he has distributorship in Maharashtra, few areas of Maharashtra. I'm not certain where. You can just call him and ask him where all it's available, and whom maybe he'll have contact in your region as well. So you can just.
So that is what, these are things, because basically morphine is something which is essential, and then not all centers do have it. So everywhere we try to find out where all it's available and then send patients there, so that at least they can get access to it and have a pain-free, easing the pain gives better quality of life.
Yeah.
Okay.
Yeah.
And In that case, I will hand it over to Anup. Thank you very much, both Dr. Parvati and Rutula.
Thank you, ma'am.
Anup is around.
Thank you, Rutula ma'am and Tata ma'am. Thank you all the participants for joining us. This is Anup signing off from TikTok. Bye.
Thank you, one and all.
Thank you.